Welcome to Rochester Lifestyle Medicine Institute and the William J. Folletti Center for Lifestyle Medicine Grand Rounds. I am Dr. Ted Barnett, the president and founder of Rochester Lifestyle Medicine Institute, and it is so great to have you all here tonight. We have a great case and a great case presenter and a great guest panelists. We'll be hearing about a case of hypertension and chronic kidney disease in an avid gym goer. If you'd like to partner with us, we'd love to help you work to change the medical paradigm along with us. And you can empower your patients. We have online referral forms on our website. We have standardized programs to build motivation and competence in a socially supportive, interactive environment. 2 of our programs are ACLM certified, including our 15-day whole food plant-based jumpstart, which we developed. And you can see there's first 2 columns there are actually also available for CME. So if you go through one of our programs, either the Jumpstart program or the Lift program, you will receive 10 free CMEs and a reduced price of only $49 to cover the licensing. So please respect the privacy of whoever the patients are in the cases. And I just want to tell you a little bit about our guest presenter tonight. Dr. Kerin Rosen is a third-year family medicine resident at Crozer Health in Philadelphia, where she is additionally working towards board certification in lifestyle medicine. She's also a +1 fellow in Loma Linda's preventive medicine residency. She obtained her certificate in plant-based nutrition from the T. Colin Campbell Center for Nutrition Studies and E. Cornell. Dr. Rosen's interests include plant-based nutrition, public health, and food politics. Our guest panelist tonight is a nephrologist. Dr. Rebeca Monk is at the University of Rochester, where she's a professor of medicine and has been chief of medicine at Highland Hospital since 2022. She has served the health system for almost 30 years, most recently as chief of the nephrology division at Highland Hospital and medical director of the Highland Hospital inpatient dialysis unit. She served as program director of the URMC Nephrology Fellowship for 12 years and served the CRRT program at URMC in 1994. She's medical director of the Irondequoit Bay Dialysis Unit in Webster, New York, and she also serves as an advisory board member to Rochester Lifestyle Medicine Institute. And these are our regular panelists. I'm just going to give their names for the sake of time here. Dr. Robert Breakey, Dr. Melissa Sundermann. Dr. Kerin Rosen is our new medical director and also helps to wrangle our cases. So we refer to her as the case wrangler. I am the moderator for tonight's event. And we thank you for coming tonight. As you know, we are a nonprofit. My wife and I are full-time volunteers for Rochester Lifestyle Medicine Institute, but we do pay our staff because we are generous like that. So please consider making a donation. And now it is on to our case, hypertension and chronic kidney disease in an avid gym goer.
Thank you all for having me. I'm going to be talking today about a pretty fervent weightlifter who has a plethora of health conditions stemming from it. We're going to spend a little extra time talking about the hypertension and the chronic kidney disease. I thought that was perhaps the most educational. So our patient is a 59-year-old male. He has a history of CKD3A, GERD, AFib, hyperlipidemia, hypertension, sleep apnea, obesity. He's coming into the office for pre-op clearance for foot and ankle surgery with podiatry. He's had 4 previous ankle surgeries, total knee replacement. He's done well in the past. He's on numerous medications, mainly for this hypertension and AFib, lisinopril, HCTZ, metoprolol, diltiazem, Xarelto. He's on a statin. That said, he's filling them maybe a third of the time he's supposed to be, so definitely very iffy compliance. I'm going to chug through his history a little bit by going through the pillars. So as far as nutrition goes, he's aiming for a whopping 200 to 250 grams of protein per day. His diet is very heavy in burgers. I'm in Philly, so he includes those cheesesteaks and eggs. As far as exercise goes, he actually owns his own gym. He's a power lifter. His cardio is limited. He has ankle and foot and knee injuries. For substance abuse, he doesn't smoke. He only has 1 to 2 drinks per month, and he denies drug use. I included that little asterisk there as I did have suspicion. I will come into that later. Healthy relationships, he's single, but he has a pretty social job. We didn't get to discuss stress. And as far as sleep goes, he does have this history of sleep apnea, but he says he's using his CPAP most nights. For his vitals, his temperature, heart rate, SpO2, respiratory rate, all were appropriate. His BMI is 35, but we can take that with a little bit of a grain of salt because he is a weightlifter, but there was some adiposity there for sure. And then for his blood pressure, he was rocking 160s to 170s, over 90 to 100 during his visit. And like I said, this man is just a cornucopia of lifestyle problems. Much of what I'm going into today is going to be about hypertension and kidney health. So I'm going to start with a little physiology, and I think I have a quiz before we get started. All right, so hypertension, it can be both caused by the kidneys and of course worsen kidney function itself. And I wanted to see which of these following renal changes is not going to be seen in chronic hypertension. Prolonged sympathetic activity resulting in a decrease in renin production, prolonged hypertension leading to structural changes in the nephron, which in turn increases sodium reabsorption, the kidney sending afferent signals to the central nervous system, so telling it to increase its sympathetic activity, and SGLT2 is upregulated over time, resulting in enhanced sodium reabsorption.
All right, so I'll ask our engineer to pop up the poll. Thank you, Bob Frankie.
I'll just say that I'm a nephrologist and I found this to be a hard question too.
My apologies.
Well, good. I'm a radiologist, but now I don't feel bad that I have no idea.
Just to put it out there, it's not straightforward.
Right answer snuck through here at the top here. With the prolonged sympathetic activity is actually going to increase renin production over time. And we're going to talk about that.
So that's the correct answer?
Yep.
Yes. All right. Let's Dr. Monk, do you have any comments at this point?
No, I'm going to let Carrie take it away. Go ahead.
Okay.
All right, so I'm going to subject you all to a little bit of physiology here. And I think it's relevant because we're going to talk a lot about the kidney, and it really helps to drive home all these areas where we can use lifestyle medicine to intervene with hypertension, and also when we're using medications, all these different areas that they're acting in. So starting with the kidney, which we're focusing on today, this is the answer to the first question. So of course the kidney produces renin. It's the rate limiting step of the ROS system, but its production is typically pretty tightly regulated. But if we're in a situation where there's prolonged sympathetic activity, there's a loss of nitric oxide, there's oxidative stress, there's increased protein filtration, so chronic hypertension, its production is going to just go kind of haywire in the kidney itself. Other stuff going on in the kidney. We have a rise of blood pressure in a healthy person should result in pressure diuresis and natriuresis. But in hypertension, your set point is kind of advanced. And the reason for that, from what I could see, has to do with the increase in pressure in this renal interstitial pressure actually alters our sodium transporters, which is going to include your SGLT2 transporters. So that breakdown, you get this breakdown in your system to bring you back to your healthy point. And then the kidney itself impacts sympathetic tone. Excuse me. There's a lot of sympathetic activity, of course, going into the kidney. But interestingly enough, the kidney is sending some activity back up to the central nervous system as well. And then vasculature, I'll run through a little bit quicker. Of course, we can get an increase in your vasoconstrictor hormones, and vascular response might be amped up as well to like your angiotensin II and your catecholamines. We can have impaired vasodilation, which can be due to your endothelium-dependent vasodilation, misfiring, no nitric oxide, remodeling. And then we can have a stiffening of your large arteries, mainly your aorta, which is going to be both a cause of hypertension and a result of it. And then lastly, and briefly here at central nervous system, of course, there's going to be an increase in sympathetic outflow that's going to cause hypertension. But on the flip side, we do have some incoming signals coming from the kidney, from the heart, and adiposity as well. I know this was a little bit complicated. It was complicated for me. I don't know if anybody has any corrections or things they want to add on.
I guess, this is a nice review, Carrie. I think hypertension is so complicated and there's so many different aspects to it. One of the things I just wanted to, there's always new things that we're learning about sodium. You all probably know that being lifestyle medicine people, that in addition to sodium intake, there's the kidney senses a lack of potassium, and a low potassium seems to turn on signaling to even hold on to more sodium, even when you're euvolemic, even when your volume status is okay. And so we're learning that there are these kinases in the renal tubular cells that will it's like this like switch that will, it's almost like the opposite of thiazide diuretic, that if you're not getting enough potassium, which is in a lot of fruits and vegetables, and you're eating already a lot of sodium, it's almost like having the opposite of a thiazide, and you're going to even hold on to even more sodium, and that can lead to hypertension. So just a little addition, a little lifestyle medicine addition, but it's a very complex hypertension. There's a lot of genetic causes as well, and we're also learning that there are a lot of monogenic and other genetic causes of hypertension. One of our chief nephrologist, Dr. Tulay, has been studying something called a gene called GSTM1, which apparently when you don't have when you have the 2 null allele copies, and apparently 30 to 50% of the population is deficient in this gene, you are more prone to having kidney injury in the setting of hypertension or any other injury. And it seems to be due to oxidative stress. It's a gene that protects us from free radicals and oxidation. And one of the things that seems to be protective is cruciferous vegetables, which release a substance called sulforaphane. So where she's actually doing studies in both mice and humans giving broccoli pills. So anyway, these are just a few little tidbits. Wow. I'll let you go. Okay.
Cool. Thank you. The other panelists, any comments, or shall we move on?
Yeah. My only comment was to piggyback on what Dr. Monk said. The only thing I can add to that is talking about those genetic variants. There's some companies out there that are offering this. And so I had a call last week or the week before with this company IntelX, but it's 2 X's because it's a female that founded it, IntelX DNA. And that's exactly what they do. They basically will look at all your SNPs and your genetic variations to disease states like propensity to hypertension or kidney disease or diabetes, and identify those gene variants. And then, like you said, make recommendations to, okay, this is like what you're predisposed to genetically, and these are some recommendations. So there are companies, and I listened to the reason why I knew is I listened to a podcast that the founder was on there. So it's INTELEXX DNA, and they're doing some really cool things.
Wow, thanks for that. Dr. Breakey.
Yeah, I guess the only caution I give, obviously genetics is important, but remember, genetics slows the gun and diet pulls the trigger. When you look at African villagers, they studied over 3,900 African villagers, and they had 0 cases of hypertension, 0 cases of diabetes, 0 obesity. Now, those same folks here, African Americans obviously have higher than average incidence for Americans here. The genetics haven't changed in 150 years, but their diets have. They've gone from 80% carbs with cassava, maize, vegetables, fruits, to the standard American diet. So I caution people to think like, oh, I'm genetically prone to this. It's just why I have it. I can't do anything about it. I better take meds. Rather, you should say, oh, I've got this genetic tendency. All the more important that I don't allow it to express. And that expression comes either in the form of just more easily overwhelming the systems by the American diet, or epigenetics, which is commonly monitored or mediated by the microbiome. So yeah, thank you for bringing those up, but I just want our folks to recognize that genetically, the genetic tendencies isn't a, oh, well, I can't do anything about it. It's all the more important.
Thank you for that. All right, Dr. Rosen, back to you.
Back to me. And this is actually kind of supporting what Dr. Breakey was just saying. When I was looking through research, I was reminded of the rather infuriating fact that when they came up with this DASH diet that we hear over and over and over again, it was made to have the blood pressure lowering effects of a vegetarian diet with still being palatable for the public. And then we can see when you look through these just like endless studies on plant-based diets and hypertension, why they included it, although it's infuriating they didn't include it more. But I looked through, these were just a few things out of many I found. There have been so many cross-sectional studies, 2 of the more famous ones being the EPIC Oxford study and the Adventist Health studies. This meta-analysis here looked at over 20,000 participants, and they found that A vegetarian diet was associated with a lower blood pressure compared to an omnivorous diet. There's also another meta-analysis from 2020 looking at RCTs this time, which again found that vegetarian diets significantly reduce both systolic and diastolic blood pressures compared to vegetarian diets, although the vegan diets did tend to win out a little bit more than the lacto-ovo-vegetarian. And then, interestingly, there was a study done a couple years ago by PCRM looking at the Mediterranean and low-fat vegan diets, comparing the two. And the low-fat vegan diet did win on a number of things like weight loss, but they did find that blood pressure was slightly, both were resulted in lower blood pressure, but Mediterranean diet did lower it slightly more, which the authors theorized had to do with the monosaturated fat content in the Mediterranean diet, vitamin E, and enhanced antioxidant capacity. But they also put forth that all these things could be gotten from a plant-based diet as well.
Did they notice the sodium content in each? Did they compare the sodium content?
I remember actually.
That's all right.
Yeah.
Sometimes that makes a big difference. Okay.
Yeah, absolutely.
All right. Keep going there. So back to our case. Great.
Yes. All right, so back into our exam room. This patient, in general, he's definitely muscly. However, there's a good amount of adiposity as well. He has a history of AFib, but he was regular rate and rhythm. His lungs had distant breath sounds, which I attributed to his habitus. And he had some mild chronic skin changes in his lower extremities. I will go through his labs with their disease state very closely in the next few slides, but just briefly to point out some oddities. He has a hemoglobin of 20.9. He also had an elevated red blood cell count. This was his norm. His creatinine is 1.4, GFR is 52. Again, that's where he typically sits. ALT and AST were about double what they should be, which also seemed chronic. And then he has this history of hyperlipidemia, maybe taking a statin. LDL is 165, his HDL is low, his triglyceride is high.
Did you ever check a urine protein on him?
No, that brings me to my next slide where I was angry at myself for not checking a urine protein.
Okay.
I was a pretty new resident when I got this, but I think this chart just really hammered home to me how important it would be to get a urine protein because he's CKD3A. And like, there's just such a huge range of how dangerous that is compared to how much urine protein he has in his urine.
I would argue it's not even clear to me he has CKD3A because if you go back to the former slide, his creatinine is 1.4, and he's a guy who eats a ton of meat, right? He's got his cheesesteaks and his hamburgers. And where does creatinine come from? It comes from muscle. And he's also a weightlifter, right? He owns a gym and he's constantly powerlifting, you said. So if he's got a lot of muscle mass, that creatinine may not really represent that low a GFR. We now use cystatin C as well as creatinine, which gives us the best estimated measure of kidney function. So this is a good start, but I guess we now, especially now that we've taken race out of the equation for kidney disease, we've been using a lot more cystatin C. And the best, like I said, the best equation is one where we actually input both the creatinine and the cystatin C, which we now get in-house in all of Rochester. We brought cystatin C into all our in-house labs. And if his creatinine is really from muscle, cystatin C does not rely on muscle. So maybe his cystatin C might be the equivalent of 1.2 or a 1 kind of creatinine, and then his GFR might be over 60. And if his GFR is over 60, by definition, he doesn't really necessarily have chronic kidney disease unless there's other evidence of kidney damage like protein in the urine, or that we've done a biopsy that shows that he has some kind of nephropathy, or that we see some sort of imaging like polycystic kidney disease that shows that he's got kidney disease. So he may or may not, and the other part of it is that people who, if you're eating someone else's muscle, if you're eating like the cow's muscle, even if you've ingested some muscle within a few hours of getting the blood work, that can raise your creatinine by almost up to a point in some studies. So it's not really clear to me that he really has CKD, but his creatinine, his B1's a little high, and those other labs are pretty crazy, so I'll let you keep going.
Well, actually, I'd like to hear comments. I'm kind of interested in these labs. Dr. Breakey, you want to comment on these labs?
Yeah, I think you're probably going to comment on the liver function tests also. He's got obesity and he's likely got fatty liver. That visceral fat that can invade the liver, the pancreas, even the kidneys can have adverse effects as well. And again, remind me of the X over there. Which one is his hemoglobin?
It's 20.9.
His hemoglobin is 21.
Mm-hmm.
So he's significantly polycythemic, but he's not a smoker. He's just, all that heme iron is just kind of being forced in, and the body needs to do something with it. Might as well make some extra red blood cells. That's also, of course, going to increase the viscosity of his blood, decrease his peripheral flow to capillaries, and the kidneys are very sensitive to that. Obviously, all of those capillaries have to form a tight capsule around Bowman's capsule there. So I don't interesting. We'll see what comes of this, but he's not way out of trouble yet. I see reversibility, but he needs help.
Yeah, so
I'm sorry. Go ahead.
I'm
Yeah.
looking at this and I'm saying this guy is definitely using anabolic steroids. I mean, looking at that high hemoglobin hematocrit, we know that anabolic steroids can also contribute to fatty liver. And then he's on a statin and his lipids do not really look that great being on a statin. And, even though he's in the gym and he owns a gym, his HDL is, we want that to be 40 or above, and it's pretty low. And we know that, there's a genetic component to HDL, but also exercise. So his lipids look horrible. I think the polycythemia is probably related to anabolic steroids. The fatty liver could be as well. Yeah, so, and definitely his 200 to 250 grams of animal protein are not helping this and his gut microbiome or anything.
I would just add that I think those liver enzymes could also be referred to as serum enzymes. They could be coming from his muscle also if he's lifting a lot and releasing. He could have a CK that's a little high from heavy lifting also, and some of that could be, it may not all be liver. And I think his sleep apnea has to be considered as some of that polycythemia also. But
Wow. This is fascinating. Keep going, please. Thank you to our panelists. So you're doing a great job.
Okay, I'm going to subject us to a little bit more physiology here, talking about chronic kidney disease. So we know that there are numerous observational studies that have linked animal proteins to worsening kidney health. On the flip side, plant-based diets, plant proteins seem to be protective. And I came across a few particularly impressive studies, which you may have heard of, the Singapore Chinese Health Study, looked at over 60,000 people, and they found actually a dose relationship between the consumption of red meat and the risk of end-stage renal disease, and found that replacing just one serving of red meat with a legume could decrease the risk of end-stage renal disease by 50%, which is actually, I quoted that to a patient today. And I looked at the mechanisms for this, many of which were brand new to me. The first one being metabolic acidosis. So fruits and vegetables are alkali producing. There's a series of RCTs by Gorea and that team that found that about 2 to 4 servings of fruits and vegetables per day have a comparable effect to taking a carb tab in raising serum bicarb. But of course, eating a fruit and vegetable is going to come with fiber and other important things. And I also pulled this kind of interesting chart from Freeman and Turner, which shows the acid load per food. And on the left is basically, it's all your cheese and your meat and such. And on the right, you just have fruits and vegetables just kind of killing it with their alkali producing activity.
I love that. And I just want to comment, that study that you mentioned about the sodium bicarb and the fruits and vegetables was a great study. That Don Wesson is the lead author on that. It's in a part of Texas where they had very underserved patients, very poor. And what they did is, as you mentioned, one of the other things to mention is that having chronic kidney disease leads to metabolic acidosis in most cases because you can't excrete the acid load. And that metabolic acidosis can also lead to progression of the chronic kidney disease. So we like to keep the bicarb above 22, normal being about 24. And if you get less than 22, you're more likely to progress with your CKD. And so we like to tell patients to have base producing fruits and vegetables. And what Don Wesson did is they randomized those patients to either the usual care or sodium bicarb tabs to get the bicarb up to 24 or above 22, or they gave the patient and their family enough fruits and vegetables for the next several weeks. And what they found was that the fruits and vegetables are the same as the bicarb, but they didn't have the hypertension that the sodium bicarb people got. But both the sodium bicarb and the fruits and vegetables were better than not having either of those in terms of protecting the kidneys. The GFR didn't decline as much. So this is great, but it also confuses me a little bit about your patient whose bicarb is 27. Why does he have metabolic alkalosis eating 200 grams of animal protein a day? That's really weird to me. So my nerdy nephrology brain is, I don't understand why he's got metabolic alkalosis. So.
Yeah, I hadn't considered that. And I don't know if I'm thinking through this correctly, if his sleep apnea might be factoring into it.
I think the sleep apnea's it's doing something. Where is he? Anyway, is it contraction alkalosis, and is he volume depleted, causing some of the, I don't know, there's something weird. It doesn't make sense.
Well,
He's on a thiazide, so maybe he has a little bit of contraction alkalosis.
Carrie's wondering if he's taking a lot of antacids for his GERD. That's a possibility. Yeah.
Interesting.
All right. Next mechanism here, if we're ready. So phosphorus. I found this incredibly interesting. So the phosphorus in plants is less bioavailable. So for all intents and purposes, plant-based foods actually have lower phosphorus than non-plant-based foods, which was really almost relieving for me to hear. I've always thought that patients having to keep track of their phosphorus intake seems really difficult, but if we can provide them with this just dietary pattern that kind of produces a better phosphorus intake than them, it seems like it would be so relieving for some patients. And then the uremia. So the kidney, of course, does the serum, urea, nitrogen, homeostasis. If you're eating a plant-based diet, there's going to be less production of nitrogen likely, but the high fiber also helps trap that nitrogen in the GI tract. You're going to have less burden on the kidney, and there's going to be less uremic toxins altogether.
That's really nice, Carrie. I think phosphorus, personally, I just want to put a plug. I think that's the biggest killer of patients with chronic kidney disease. Because when you get a high phosphorus and it doesn't get excreted, which is what happens with CKD, that phosphorus binds to calcium that's in the blood. And you get this calcium phosphorus precipitation in the media of the blood vessels. And that leads to these very, very stiff blood vessels that the heart, basically those vascular endothelial cells become more like bone cells. And if you look at someone whose phosphorus has been chronically high on dialysis and you do an X-ray, it looks almost like an angiogram because of the calcium that's been deposited. And that's from the phosphorus binding to the calcium and getting deposited. And so the heart has to, you end up with this left ventricular hypertrophy from the heart having to squeeze against this very high, SVR, this huge, all these stiff vessels. So that's a big problem, and it's true that animal protein has a lot of phosphorus, and all the processed foods are also, there's just a lot more, anything that has PHOS, hexametaphosphate, phosphoric acid. We tell our patients to avoid all of those, all of our dialysis patients, because those are almost 100% absorbed. Those inorganic phosphates that are in processed foods, like in Coca-Cola, in anything that comes in a box, 100% absorption. And animal protein also 30, maybe 40 to 60% absorbed, whereas the plant phosphorus is very minimally absorbed, as you mentioned, because of it's in these phytate rings, which are not as bioavailable.
Wow, that's fascinating. So Dr. Monk, you agree with that second point that plant foods really are? Yeah.
Yes.
Okay, obviously. Great. Thank you.
So Dr. Monk, the hospital that you round out, just curious, because I remember when I was a hospitalist way back in the day when you would order, renal diets, right? It was low phosphorus, low potassium, low protein. Are you able to shift to a plant-forward dietary pattern? Or are they just getting regular?
We do because we're fortunate. We have Susan Friedman
Yeah.
we now have a healthy diet. I forgot what they call it, but we have a vegan option for our patients
Okay.
at Highland Hospital, which we're very fortunate to have. But it's not easy, and they don't make it. They don't really advertise it. People have to kind of ask for it. We're trying to make it so it's really part of the regular. It is embedded in the menu, but it's not as easy to see. So we're working on it.
Yeah, like in New York City hospitals, right? That's where the plant-forward
Yeah.
diet is the first and second default diet. Like you have to work really hard to get any animal protein.
Yeah, Eric Adams really, is that his name? Eric, yeah, he really pushed for that. Yep.
Wow, thanks for that. Dr. Breakey, any comments?
So yeah, so far, this is excellent. Metabolic acidosis, of course, comes from the high cysteine and methionine content of the animal proteins. The sulfur metabolizes those two amino acids, the only two with sulfur, metabolize to sulfuric acid. In the short run, the kidney protects itself, having to excrete all this excess acid beyond what it's used to. I mean, carnivores, their kidneys are 3 times their weight size per body weight as ours. We're not intended to eat that much, especially animal protein. In the short run, it forms ammonia to buffer that acid, and that it becomes nephrotoxic. And then, good point on the phosphorus. So often you refer to a dietitian, they're like, "Oh, don't eat vegetables, fruits because they're high in phosphorus." Well, the atom phosphorus is in there, but it's not bioavailable. Lectin phytates means that they really have to watch out, as you mentioned, for processed and animal sources. So similar to iron, the heme iron almost 100% absorbed, and plant iron's less so. And that's a good thing. Your body's more able to absorb what it needs when it has that chance, instead of just kind of being forced in, so to speak. So great points so far. We should keep moving.
Okay, yeah, back to you, Dr. Rosen.
Right. And I didn't include this here as a mechanism per se, but just to point out that as I was reading, there doesn't seem to be any studies that demonstrate that the so-called risk of hyperkalemia from plant-based diets actually exists, which again seems to be from the high fiber content that people are getting. Right. And there's one more mechanism to go through. I threw in some probably unfair polls to see if people can remember this. Before we go through this last one on hyperfiltration, just want to see if people remember what the protein cutoff is that can cause an increase in hyperfiltration, which is a known risk factor for kidney disease. It's 0.8, 1, 1.5, or 2.
Carrie, while people are filling that out, a few of my partners and I, including Susan Friedman, who's part of Rochester Lifestyle Medicine, my partner Scott Lehman, and Tom and Aaron Campbell and I have done a study with a small number of patients looking at putting patients with chronic kidney disease on a whole food plant-based diet, and to see if hyperkalemia developed. And we actually saw that the blood pressure went down, not significantly comparing the two groups. We only had 20 patients in each group, but potassium did not go up significantly. So we're trying to get it published. I think it shows that we need bigger studies, but we were wondering the same thing. Is it safe to put people with CKD 3 and 4 on a whole food plant-based diet? And we didn't find that the potassium was dangerously high.
Yeah, thanks for that reminder, Dr. Monk. That was a randomized controlled trial using our 15-day whole food plant-based start.
Exactly.
Yeah, so we're really excited about that.
All right, you guys got it. 40% for the 1.5 per kilogram of ideal body weight is when we start seeing that hyperfiltration, which I thought was just a neat mechanism, but also confusing. So I needed to see a picture of it. The idea being here that if you take a low protein diet, it constricts the afferent, the incoming arterial, and then it indirectly, on the flip side, is going to help with the dilation of the efferent one. So less coming in, easier to get out. You're obviously going to have less intraglomerular pressure. the filtration rate is going to go down, and all that is just going to equate to less damage to the structure itself. I have another quick poll here. So at what stage of kidney disease do protein recommendations change? And I would love to hear as well if this seems to be an arbitrary cutoff or real.
I don't really know.
Well, don't say anything yet. We got to get the audience input here first.
I think this is somewhat controversial.
All right, let's take a look, Bob.
Yeah, so it's 3B is I think what the literature is saying. But again, I was curious if this is a real cutoff or just some arbitrary distinction we've made.
What do you mean by what do you mean by what are we saying that people with CKD, we want them to have a lower? Is this at the point where they should have the protein restriction, or where we stop the protein restriction?
Where we start it.
I see. I think people should start it sooner. Nobody needs that much protein. But the other side of it is that we actually stop the protein restriction when people get to about 4 or 5, because we don't want them to be malnourished once they start dialysis. A dialysis patient, if their albumin gets too low, it actually is a sign of it portends a higher mortality. So we want them to be well nourished, and we don't necessarily reduce protein once they start dialysis.
Dr. Breakey.
Not necessarily. I'm not talking about animal protein, or I'm just saying in general, Yeah.
Protein in general. Okay.
So yeah, I mean, I think that's the key point here, is that when you talk about protein recommendations, you really have to factor this for what type. So they did a study giving people 1 gram per kilogram of tuna versus tofu. And the tuna induced hyperfiltration by 36%, actually 45% in diabetics, but the tofu, equal protein amount, had no effect on hyperfiltration. Similarly, with protein recommendations, Melissa and I are holding up number 1, because compared to the standard American diet, everybody eats too much protein, or averages 50 to 100% more protein than they need. So starting at stage 0, everybody should lower their protein if you're talking about standard American. Now, somebody needs to mute. Now, on the other hand, if you're looking at RDA for 0.8 milligrams per kilogram, if you look at kidney health, that should be a maximum. You should not really get more than that, and it should be plant-based to be the healthy protein for the kidneys. Once someone drops to stage 3, a GFR less than 60, recommendations drop to more like 0.6 milligram per kilogram of lean body weight, not just obese weight. And then you could maintain that all the way down to stage 4. Dr. Monk, I know what you mean about stage 5. You have so much protein wasting that you have to be careful. But again, it should be plant protein. You don't want to add hyperfiltration, excess acidity, TMAO, inflammation, arterial clogging. We'll come back to some of this, but increase your protein. And then, of course, once on dialysis, it goes back up to between 1.2 gram per kilogram. Or I'll let you verify that. But we think of protein as protein, but it's really very different depending on the source.
You're right, and I think when we think about dialysis patients and we look at their serum albumins every month, I think a lot of animal protein can lead to inflammation, and that can drop their albumins. It's not just protein intake; it's also an inflammatory mechanism. There's a question. I don't really know that much about protein guidelines in acute renal failure. That's a good question. I'm not sure. I think I don't know if anyone else knows. I'm not aware of where we should be on that.
I don't know the answer to that question, but I went with Dr. Bob Breakey of stage 1. I think all of these, whether it's stage 1 chronic renal disease, whether it's hypertension, prediabetes, that why wait until it progresses? And, as a general internist for many years, I mean, you didn't really, if we were heading down that road and people weren't making changes, or we weren't intervening and educating, stage 1 often progresses to stage 2, to stage 3, and same thing with prediabetes to type 2 diabetes. So I think that at stage 1, just, using that as the stage for early intervention and education. And, you can make these changes now and not have to see the progression. And, we can look at all of chronic diseases, from that same standpoint of using this as, sort of that warning sign of you're already heading down this road. Let's make some changes and you can take a different curve and head down a totally different road. So I would start at stage 1.
All right, thank you for that. Dr. Rosen, we need to pick up the pace a little bit, my fault.
Yep.
So, okay.
All right, so I have 3 slides on other systems here, and we can rock through these a little bit faster. So his liver enzymes are obviously high. This patient unfortunately had pretty terrible follow-up, but this is how I think I would approach this patient. Like anyone, medication review, he's on a statin, but nothing else seems to be related. Screen for alcohol abuse, which he is saying he's barely drinking. I'd want to do some additional typical labs here, get a hepatitis. Certainly this patient with his CBC as it is, do a hemochromatosis workup. Try to better characterize the liver, get a GGT, bilirubin, INR. And then ultrasound for hepatic steatosis. I put this little asterisk here because this is obviously, aside from the drinking, where our lifestyle interventions can really help. I know Dr. Bolsewicz did a big talk on this not that long ago, but I just did a quick look around and saw that there's good data that even moderate amounts of pro-inflammatory foods, so your red meat and your processed meat particularly, are associated with more non-alcoholic fatty liver disease. There seems to be about a 36% increase in risk, actually. And then for this patient, I was thinking about some other possibilities with him. He could have exercise-induced rhabdo. Probably getting a CK would be helpful. And then, like we talked about before, the anabolic steroid use could definitely weigh in here.
All right, let's hold off on comments and there we go. Great.
So on the topic of steroids, this patient's interesting because we have like a lifestyle explanation for all of these problems, but they also can kind of comically fit into the steroid picture. So running through signs of it, cardiovascular signs, cardiac hypertrophy, he had LVH, he has hyperlipidemia, he has hypertension, he has erythropoiesis. Neuropsych-wise, he later in the appointment became extremely irate and labile, so we can check off the aggression there. On physical exam in females, you're going to see acne, hirsutism, hair recession, amenorrhea, voice changes. Males, also the acne, hypogonadism. He did have some ED going on, gynecomastia, and then liver disease and kidney disease. And then just quickly on the topic of the erythropoiesis, which we brought up, I mean, it was mentioned about the heme iron. Could definitely be just hypoxia. He has OSA. He says he's using a CPAP. I'm not quite sure what that might actually look like to him. He's not smoking, no known pulmonary disease. So it definitely is a little confusing. And then I believe the last disease state here that I wanted to run through was his AFib. And there are just so many lifestyle, triggers or protective elements for AFib that I went through the pillars here. Starting off with nutrition, we have really good data that diets high in processed foods are associated with increased risk. Interestingly, I couldn't find anything linking whole food plant-based diets to specifically a lower risk. But that said, we know things like diabetes and hypertension and obesity are risks. So it's obviously going to play a part there. And almost the same existed for exercise. I couldn't find any solid evidence saying you exercise more, you have less of a risk, but of course it helps with these known risk factors. And there is this new evidence suggesting that exercise does reduce disease burden once you are an AFib patient.
Actually, I think there's evidence that AFib actually can be caused, and it's very common in long distance runners. Get that larger left atrium. There's like an increase in atrial size that can lead to some AFib with some exercises. I don't know if weightlifting is one of those that might cause it.
Seems like the endurance risk is actually pretty high.
Is that true, Dr. Sundermann? Is that your experience?
Yeah, no, I definitely, as a long distance runner, I don't have it, but yeah, I have heard that, that there athlete's heart, right? Which can low heart rate, but also could be an increased risk for AFib.
All right.
All right, substance use. So they're at least high levels, possibly moderate levels, are associated with the risk of AFib. I appreciated the stat that with each additional drink per day, there's an 8% rise in risk, which I think is just a really tangible thing for patients to wrap their head around.
Mhm.
Relationships, this was admittedly a little bit harder to research, but some social determinants of health, like living alone, gender inequality is associated with worse outcomes. Not so surprisingly, emotional physical exhaustion is definitely implicated in about a third of cases. Certain mental diseases like PTSD has been associated with an increased risk. And then sleep, obviously OSA is this huge salient factor. I was interested to see that if you are using your CPAP like you were supposed to, your disease burden is actually very similar to someone who doesn't have any OSA.
All right,
Right.
let's go back to the patient and then we're going to discuss those last slides. So go on to your next slide, please. Great.
Back to our patient here. So given his uncontrolled hypertension, his medication noncompliance, he wasn't cleared. He was referred to cardiology. As I mentioned, he got really irate, which was really what set my kind of alarm bells off for possible steroid use. As I was chart checking him, prepping for this, I saw he did visit cards. He had a stress test, he had an echo, which the results were very predictable. You know, he has uncontrolled hypertension, so we have severe left ventricular hypertrophy, mild left atrial enlargement, aortic root looks sclerotic, there was ascending aortic dilation, his EF was intact, and that EKG fit the picture as well with that left ventricular hypertrophy.
All right, let's go to the poll and then we're going to open this up.
So this poll is kind of selfish for me because I reached out to this patient before doing this and strongly encouraged him to come back to the office.
Okay.
And I'm trying to figure out how to approach him. So I'm seeing if you practice lifestyle practitioners would stick to a pillar, or given how severe his disease states are, if you think it would be more effective to concentrate on like heart health, hypertension, kidney disease versus a pillar.
Let's see what the recommendation is. There's no right answer here. Interesting. All right.
More lifestyle people.
Yeah. Let's start with Dr. Monk.
Actually, my choice was not here. I would have focused on, well, I voted for hypertension, frankly, because I think his hypertension is way out of control and it's causing his left ventricular hypertrophy, which I think is putting him at great risk. But I also, I mean, I sort of feel like you can approach several things at once. I really think the sleep apnea needs to be addressed. And if you, I mean, obviously, if you can get him to lose some weight, maybe that'll go away, no doubt about it. His adherence is in question, and there are probably many good reasons why he finds it hard to adhere with 4 different blood pressure medicines, most of which are not very powerful or strong. He might get better with 2 stronger blood pressure medicines. I think I like the lisinopril because it, in general, it can reduce his left ventricular hypertrophy, but it's not a very strong blood pressure medicine, and that may be something we want to work on sooner while you're working on lifestyle factors, low sodium, and getting him to lose weight. But I worry about his high blood pressure, and I worry about his sleep apnea contributing to, I'm thinking maybe his irritability isn't steroids, maybe it's not enough sleep, and that Pickwickian kind of hypoxemic picture that may be causing the polycythemia. So,
Wow, fascinating. Dr. Breakey.
Yeah, it's clearly the answer to this one is all of the above. It's a trick question. And I would base it mostly on the approach to him is base it mostly on this readiness to change model. I assume you've been talking to him about diet. And if he says, look, I know I need the protein, I'm not changing, leave me alone, then you got to move to the medicines. If he says, I can't take medicines because they give me side effects, I hate them, then you've got to focus on nutrition. And again, it's tricky, but somehow you got to tease out what is he using, what else could be a factor here. Hopefully you know him well enough as his family doc to be able to get frank conversation. I'm really trying to help you here. What else could you be using that could be affecting this? For example, in the gym, a lot of people use steroids, and see how he responds to it. So I know you're right. This is a hard one to choose because the answer is all of the above.
Dr. Sundermann.
Yeah, I agree with both panelists. And I think I'm wondering if like some motivational interviewing, sort of with him, of having him answer his own question of it, his livelihood is being impacted because he really wants to have these orthopedic surgeries. And it sounds like that's something that's really important to you, because you want to be active. You have these chronic health issues. Why do you think you have those chronic health issues? And almost flipping it to him, to have him sort of go down that road. Well, maybe is it something that like my lifestyle? Well, what do you think in your lifestyle could be contributing to this? Because if he is using anabolic steroids, I mean, these people by now you would think that they would know that could contribute to some health issues. So I don't think he's probably completely in the dark, but maybe doing a little bit of motivational interviewing with him, because it sounds like he gets a little bit irate when, when you're going like this and you should and you can't and you won't. But so maybe, flipping it so he is coming up with his own answers, and then thereby you can guide him towards some solutions in the pillars of lifestyle medicine.
That's interesting. Yeah, I mean, my thought, honestly, the only thing motivating this guy, the only reason he's coming to see you, right, is because he wants the ankle surgery. Mm-hmm. So that's his, right? That's kind of his why. That's the radiologist opinion anyway. All right. So, yeah, this was great. Just in general, any other comments about the case before we open up to the audience, Dr. Monk?
No, it's an interesting case. It seems like he's a little bit of a challenge to motivate, as everyone said, as and I don't know, but I think I agree with Dr. Sundermann. I think you got to figure out how to get him on board, and maybe it is with this surgery, and just say, this is a wake-up call. We found all these things while working you up for this ankle surgery, and they can really, you want to keep working out, you want to do all these things, but we really have, with this wake-up call, we can actually help you live longer. You've got these heart issues. You may have kidney issues. We'll check his protein and find out if he doesn't have. I don't know. I think scaring him with the prospect of heart failure and strokes is not going to work for him. Maybe it's more the carrot than the stick for this guy, and it might be. I don't know. Maybe I don't know if anyone in the audience has any thoughts about that. It's a tricky one.
Yeah, let's open it to if anybody wants to go live.
Someone would I'd be asking what he wants for his health moving forward. That's
right. I'll just read a question from the chat here. What was it about creatine? What was the question, I think? Well, anyway, all right. We got Dr. Gath. Did you have a comment? I saw you turned on your camera there.
Oh, it's been on. So remind me about in the one poll, it was talking about the recommendations for protein intake for ideal body weight. Should we be doing all of our protein stuff for ideal body weight and not actual body weight? And are we vastly over giving people higher estimates of, or do people think that they should be getting a lot more protein than they are because they're basing it on their actual weight and not ideal body weight? And I just missed that memo. So that's my big question. So like when we talk about the 0.8 per milligram per kilogram, it should be 0.8 per milligram per kilogram for somebody's size for an ideal body weight, not the actual weight that they are.
Yes, the RDA is for ideal body weight. Now you got to remember there are different body types. The mesomorphs are going to have more muscle, and their ideal body weight, like you said, this guy's BMI is 35, but he might be more like a 30 because if he's mesomorph. But yeah, Carrie, that I wrestled with that a little bit too, and I looked it up. It's really, and you think about it, adipose tissue doesn't need protein to it needs a little bit to make enzymes and rebuild itself, have turnover. But the turnover, the 100 grams a day that we all turn over as a result of 80 billion cells a day dying, 80 billion cells new using, is equal. All you have to do is top that off with about another 50 grams a day for most people.
Nice. So
That makes a
thanks
lot of
for
sense, especially like for older folks, when you're talking about kind of needing a little bit more protein. Well, they need to be correcting that for ideal body weight. And so we're really not, they're really thinking they need to get a lot more protein. And when they're frustrated that they're not able to get it with a plant-based diet, for those folks, we just got to remind them to adjust for ideal body weight. Okay,
Right.
that's good. That's great to know. Thanks.
Yeah.
And I love the cat, Dr. Monk. What's the cat's name?
Teddy.
Teddy.
Just like you,
perfect.
Teddy. He's your
Very
cat.
great. So we're going to officially end, although I've asked the panelists to stick around a little bit longer if there's some more discussion. But you will be receiving an email with a link to a survey. Fill out the survey, hit submit, and you will receive a CME credit for one credit on a PDF. And we'd love it if you'd consider making a donation to Rochester Lifestyle Medicine Institute, and also help to support the Lifestyle Medicine Grand Rounds and our Pale Blue Dot communities, which you should have a link to, so you can see how to see the video when it's up. And so thank you all for attending. We are officially dismissed, but does anybody else have anything else they want to talk about? You can unmute, so Melanie's turned on her. Oh, go ahead, Melanie.
Yeah, I had a couple of things I'd like to say. First, I just want to say this has been really great. I've learned a lot. It's been really fascinating. I really appreciate it. I have a friend of mine who's an 80-year-old man who got tired of being sick, and his kidneys were tanking, and his albumin was like scary low normal and swelling and all kinds of things. And in 6 weeks, his kidney values went back up to 67 in 6 weeks. And his albumin, and I looked at his blood levels for 3 years, and his albumin levels were low, all the tests for 3 years. And in 6 weeks, he went from like low, scary, swelling problem albumin to high normal. And I just keep
Is that on a whole food plant-based diet, or what?
It is complete, well-planned, whole food, plant-based diet, and going all in. He didn't eat anything like that before. And one of the things that I said, he's heard me talk about this for years, and he got tired of being sick. And I just said to him one day, and this is what was coming up for me around this fella. I just said to this person, I just said, what do you want? Like, what do you want for your health moving forward? And if you continue doing what you're doing, you have every right to do it. But if you continue with this, you are not going to like what's going to happen to you. And this is somebody I love dearly, who is a friend. But I've also found, even with people that I don't know, with kindness and love in my heart, like it has to come from that place, just telling people the truth. And what I've learned, because I've tried throwing so much information at people and it just doesn't work that well, right? So just sitting back and letting people, I love what Dr. Sundermann said about motivational interviewing, right? Like what is your why? What's important to you? And are you okay with this? Because this is going to get worse, and it doesn't have to. There's a possibility you can reverse this. And I said to this 80-year-old man, I said, I have no idea how far, I know this, that your body systems are going to improve a whole lot. How much better all these disease processes are going to get, I have no idea. But if you're in, I'm in, and let's find out, right? And he has, and it has been, I've even been surprised. One thing after the next thing, after the next thing at 80 years old, that it's just been amazing. So I just want to say that. Thank you.
Yeah.
Really
Thank you.
cool.
I love that. I know those of us working in lifestyle medicine, that's one of the most satisfying parts is that everybody improves. That doesn't mean everybody gets all the way better or reverses everything. But just like when you quit smoking, when you quit eating a diet and you're couch potatoing and you're not sleeping and you're stressing and you get those things out of the way, your physiology works better, your body heals, it goes into good mode. And one quick point on your protein too. We're so used to deficiency challenges like, oh, your B12 is low, take B12. Your vitamin D is low, take D. Your protein's low, take protein. No, if your serum proteins are low, it's not for lack of amino acid substrate, it's that your liver isn't building them. The liver makes serum proteins and especially albumin. And if it's all clogged with adipose and just strained by, liver does over 500 different chemical reactions. And if it's overstrained by a standard American diet filled with pro-inflammatory compounds, lack of fiber, it can't do its job well. So you're right, lower your animal protein, lower and increase your plants, and your liver will work better. Your serum protein will go up, and you get out of this downward spiral of edema leading to anasarca, leading to heart failure, leading to ulcers. It's just sad to see people in that state. And then they're often given advice like, oh, protein's low, eat protein, especially chicken and fish, get the good proteins. The exact opposite is true. So thank you for
Right,
bringing
and
that up.
remembering that albumin is an acute phase reactant too. So if you are inflamed,
Right.
your albumin could be phase reacting low. And it's just because your whole body is inflamed.
Yeah.
I think
And
I
Dr.
saw,
Breakey, sorry, this person also had a lot of liver scarring. Also, yeah. Anyway, so
I think what I like about the way you presented it to him, Melanie, is that you presented it with care and sympathy and not judgment. I think that a lot of times people do respond to like this judgment that we're judging their diet or judging their lifestyle. And I think it's important to, as you did, bring it up with care. And, it sounds like he finally listened. I don't know I don't know why sometimes what tipped him over? What did he just get to some point? I don't know, but
That's great.
he's
Yeah.
got a lot more he wants to do. If I may, I'd just like to ask one question to see if anybody here has any thought about this. This same person has terrible dry mouth. And my suggestion was you may want to get checked for Sjogren's. So that's coming next week. But I just am curious if anybody, it's a problem. Like his tongue gets sore, it's very dry, it's very uncomfortable. That's the one thing that this really hasn't impacted. Does anybody have
on any anticholinergic drugs, any medications to be
He was on
anticholinergic?
tons, he's on none now.
No, wow.
I just want to mention I'm sorry, in the chat, Dr. Berkowitz is saying that he's reluctant to advise patients that a whole food plant-based diet is capable of reversing chronic kidney disease in terms of when you really do have established chronic kidney disease with really significantly low GFR and structural damage. It's true. I can't say, it's hard to know if your 80-year-old gentleman may have had an acute component of kidney injury or, some of it may not have been. Maybe there were things that were not fully true chronic, sclerosis that was irreversible. So we certainly don't want to promise everyone that we can reverse it, but we can certainly hope to stabilize. So I do agree with that. Yeah.
Right. Thanks. And that's what Dr. Berkowitz is, my other favorite nephrologist, along with Dr. Monk. Dr. Berkowitz is out in Ann Arbor. So with that, I think it's time to wrap it up. So I want to thank our case presenter. Carrie, your punishment for giving such a good presentation is that we're probably going to ask you to do it again, because that was really fantastic. And Dr. Monk, I have to say, you're one of our, well, I can't say that. You are a fantastic
You have another favorite. You have other favorite nephrologists.
You're a fantastic guest panelist. We would love to have you back again as well, because I think this was I thought this was a really outstanding LMGR. And of course, our regular panelists, Dr. Robert Breakey from Ann Arbor and Dr. Melissa Sundermann from Ann Arbor. You did a great job as well. And Dr. Kerry Graff, thank you for being there in the background and it's always good to know you're there in case something happens to me. So, as you know, anyway, and Melanie, thanks for you're highlighted too. So thanks for that comment at the end. And
here.
yeah, thank you everyone in the audience.
Dr. Barnett,
Yeah.
did anybody, I just put it in the chat too. Did anybody have a thought about that? Any
About-
suggestion or thought or test or somewhere I might send him? Or he's really suffering with this.
Well, I think the
At
idea of
any-
an autoimmune was go ahead. But
At any given time, 20 to 30% of adults over 65 are dehydrated. Obviously, you've got to make sure he's drinking enough water and that he's not eating too much salt or sodium, which can pull fluids out. But in your case, where it's just so prevalent, it's all the time, not just intermittent. I would agree some kind of autoimmune is the most likely.
Makes sense. Okay.
yeah,
All right.
yeah.
Thank you.
Great. All right. And with that, thank you all. We'll see you next month.
All
Thanks a
right.
lot.
Thanks,
Thank
Ted.
you.
Great
Thank
job.
you.
Good to see you all.
Bye-bye.
And thank you,
Yeah.
Bob Frankie in the background there, our amazing engineer.
Yeah, thanks, Bob Frankie.
Bye-bye.